Welcome everyone. Today we are here because of second part of Global Guidance and Counseling Congress. Uh, Today I'm the presenter and our moderator is Associate Professor Nadire Gülçin Yıldız. Our guest is today Miss Solmaz Bulut. Firstly, welcome.
Thank you.
Miss Bulut.
Thank you.
Our topic is today family-based crisis intervention for adults. Yes, teacher, you can start, please.
Sure. Let me try to. Hi, everyone. First of all, I will say that I'm super excited to be here with you all. And I am going to talk about our program, Youth Evaluation.
Maybe, sorry, should I go ahead and do the introduction?
Yeah, please.
Okay.
Please, teacher.
My apologies.
No, that's fine.
Sorry. Maybe there is a little confusion. I thought you are just opening the program. I will be doing the introduction. Anyway,
Okay,
because our presenter has such an impressive CV, you should know a little bit about what she does, what she do, where she is graduated and stuff like that, so that before we get started. Solmaz Bulut is going to present on family-based crisis intervention. She is a licensed professional counselor, licensed behavioral health wellness coach with a master's degree in counseling psychology from Oklahoma State University. She has been working in the mental health field for 20 years as a college counselor, mental health counselor, therapist, team leader, clinical supervisor, and researcher. As leading both inpatient and outpatient patient services with interdisciplinary teams that provide intensive community-based services to individuals with severe mental illness, both adults and children. These individuals often have complex mental health needs, including acute psychosis, histories of complex trauma, co-occurring substance use disorder, and a high risk of homicidal, suicidal ideation. Solmaz has completed training qualifying for the certification in trauma-focused cognitive behavioral therapy, parent-child interaction therapy, dialectical behavior therapy, celebrative assessment and management of suicidality, secondary trauma, components of enhancing clinical experience and reducing trauma, certified community behavioral health center, cognitive behavioral therapy, dialectical behavioral therapy, level of care utilization system, motivational interviewing, seeking safety, peer recovery support specialists, supervisory training, written exposure therapy, zero suicide summit, clinical supervisory training. Additionally, Solmaz published some articles in national and international journals, mostly focused on PTSD. Solmaz's practice is based on helping adults and adolescents gain self-awareness, insight into their problems, coping skills, and resiliency to live healthier and more productive lives. She uses an eclectic approach that leans heavily toward client-centered, CBT, DBT, and motivational interviewing. Solmaz is currently working as a program director at Youth Evaluation Services of Tulsa, at Counseling and Recovery Services of Oklahoma. Now we can start listening to her presentation. Thank you very much for sparing your time and being with us tonight. We have sorry.
Thank you so much for the great opening, Dr. Yıldız.
Yes.
Hi, everyone. Good evening. I will be presenting today our new and exciting program. Let me try to share I was telling Dr. Yıldız that I'm not educated, I'm a clinician, but I will do my best to share my experiences as much as I can and try to be helpful and motivating these beautiful young people as much as I can. Let me try to share my screen that I prepared for this. Okay. Can everyone see my screen?
Yes, we do. Yes, probably all of us.
Okay, perfect. When Dr. Bulut asked me that come up with subject and talk about, and I told him that I have been working inpatient, outpatient facilities, that there's so much information, I don't know where to start. And he said, since you have this brand new program, why don't you talk about your program and try to educate us how you guys utilize what you guys do in your new program. So Urgent Recovery Center, in the US, there are 100,000 of urgent recovery centers to serve services for the adults. However, in youths ages 5 to 17, it's a brand new concept. And we are in Oklahoma. We started this project. We had a grant. We applied for the federal government due to recent suicidal attempts and other things, which I'm going to talk about that in my second presentation. And we come up with this brand new model that it's now becoming more popular. We serve youths ages from 5 to 17 years old. We are not inpatient, we are not outpatient facility. It's like almost a hub. When youth are in crisis, families sometimes they don't know where to turn. They go to the emergency departments, or they have been calling 911 phones to be able to seek help, because the numbers of providers are limited, and there's so many people, so many youths are in crisis, and there is not enough services for these youths. So we are kind of a gap between inpatient and outpatient facility. We provide trauma-informed emergency mental health disorder screening and assessment. Like I said, it's a immediate responses. We have a home hotline. If the youths are in immediate risk, they will be able to reach us out, and we do the basic screening, which I'm going to go in a little bit step by step to explain what we do. So why the most important thing about this youth evaluation services of Tulsa is a family style model of immediate crisis response. Most places that in application, they do either family therapy weekly basis, or we have been found out that parents or family members, they will be dropping their kids to emergency departments or inpatient facilities, and they don't involve with the treatment, which we all know. We are in the mental health field. 80% of the reasons are the parents' behaviors or their own past traumatic events cause these kids, or they are coming from a disadvantaged family backgrounds that they don't have enough tools to be able to lead or educate or teach their kids how to cope with the stressors. Okay. So why we needed urgent recovery centers for youth? Again, this is a pretty new program. It's having well established. It started in 2021. Emergency, the American Pediatric Association, American Psychological Association, American Mental Health Association for Children, they declare national emergency in children's mental health. In 2020, suicide was the second leading cause of death in youth ages 5 to 17 years old. And can you imagine that kids are having suicidal attempts like start from 5 to 17 years old? Between 2016 and 2020, these numbers were jumped in 57%. The youths are attempted suicide or they engage with high risk behaviors, 57%. And according to, again, this research studies from SAMHSA and NAMI, the anxiety and depression have been increased significantly. According to research studies, again, show that this time frame, one in 5 child is experiencing mental health or substance abuse related issues. And of course, this is influenced by pandemic too. The kids have been in the United States. I'm not really sure what's the numbers in Turkey, but over 200,000 kids and youths, they lost their parents. During the pandemic, I mean, you know, you're in a mental health profession, people have been isolated, they have the symptoms of loneliness, they lost their loved ones, their anxiety increased, especially with the youths, their peers, their friends are in that age frame is very important, and they have been isolated, they couldn't able to reach out, they couldn't able to do their maybe physical activities or after school programs, and they were all just stuck at home. And some kids are unfortunately they exposed to domestic violence or trauma or other related issues. These are the other facts that we needed to build emergency urgent recovery centers for the youths. And unfortunately, for the adult population in the United States, there are crisis centers, there are stabilization services. However, there is not any emergency crisis services that established or needed to be built. It's a brand new, like I say, since 2021, federal government came up with the idea after the declaration, they were able to fund nonprofit organizations or the organizations that work for the government, they were able to receive grants to be able to start and develop the program. Like I said, there was not any existing services to be able to help these youths in immediate services. I mean, you have been seeing on the news probably like kids are, they accessible to gun, they go to the schools and there's school shootings and excessive behaviors. So government had been, the federal government had been notified that to beside the suicide risk, we need to be able to develop, fund a system to help these kids to intervene early ages. Another fact is when kids are not being able to see, we to train providers like a psychologist or licensed therapist or health professionals that they are more into like understand the risk and risk factors are very limited. When kids go to the emergency departments in today, if they even mention about suicide, the first thing is they will send them inpatient facilities. Sending these kids inpatient facilities cause financial difficulties for all of us, for the taxpayers. But also in the long term, I mean, I experienced this in my clinical experiences that there is stigma attached. I mean, client says that, yeah, I have been in inpatient facilities on and off my life when I was a childhood. So we want to decrease that hospitalization. And also when families and youths, when they are going to trying to seek services from the emergency department, there are lines and lines. A number of people are just waiting, and there is not enough inpatient facilities to be able to do the services. Yes, they do have case managers, they do have other distracting, okay. Another reason is we all know that early interventions prevent the severe mental health and substance abuse issues in the long-lasting lifespan. So these are the main reasons that we wanted to come up with this family-style emergency services. Maybe it's a little bit confusing when people start to understand. We serve 23 hours, 59 minutes. What it means, when the youth came, our facility, we do the basic screening. After the screening, we will be leading to do the assessments. We have a licensed professionals like nurses, and I have a couple of doctors. I have 4 or 5 therapists, case managers, mental health techs, outreach coordinators. Our clinic is small, but right now we are close to 30 licensed professional people that working and trying to intervene and do the assessments and services for these families. Let me go to the next slide. Any questions so far? I guess not. Okay. Criteria for admission. For our facility to be able to admit youths or children, they need to be under age 5 to 17 years old, because if it's 18, they need to be considered adult and they need to be served other facilities. The caregiver, the parent, they need to be involved during the treatment. We have been noticing that inpatient facilities, even though in their structure there is a family therapy that needed to be done, however, that has not been successfully implemented. So one of the criteria, if parents are bringing their youths for services, they need to also stay and involve with the treatment process. It's a collaborative work. It's not only the youth, but the parent needs to learn what's the issue, how they can help, what's the barrier. There's a collaborative work with the parent and adolescents. And I think that's really makes successful this program. Our services are voluntary. However, if the kid describe and identifying disclosure in suicidal thoughts, ideations, plan, risk, and if the parents are not agree with going to the inpatient facilities, we have to call the Department of Human Services and report. That's another level, but mostly our services are voluntary. When youths are trying to seek services from us, we want to make sure that the issues are not behavioral, but related with the mental health or substance abuse issues. So it needs to be meet the criteria for the DSM diagnosis. And most of the clients that we have been seeing in our facility, anxiety, depression, ADHD, PTSD, eating disorder, these are the most common ones. Presenting issues need to be related directly with the mental health or substance abuse disorder or traumatic event. Before we accept the admission, we want to make sure that child is medically stable, because we have kids that they attempt suicide. So if they are not medically stable from the medical services, we have to send them back to emergency departments. They have to be medically stable and clear to be able to receive the services from us. And like I said, it's a crisis services. They have to be experienced some kind of a suicidal, homicidal ideation, threats, last 48 hours to be able to receive services from us. We have some exclusions for our services. Unfortunately, we are not in the state of serving kids with intellectual disabilities. We want to be able to understand and identify the problem. Therefore, that's our exclusion criteria for now. I mean, in the future, if we have more trained practitioner, we might be able to serve, but right now, we are not able to serve the kids who have low spectrum of autism too. If they're in a higher spectrum autism, if they can be able to verbalize the symptoms and identify the issues, and they can commit to safety or safety planning and understand the implementation of the safety plan, then we accept those clients. And of course, our facility doesn't right now accept kids are sexually acting out or exposure to other kids. Our capacity right now, we have 10 beds and 10 chairs. So we want to make sure that we are protecting other kids and family members. Another criteria that if the kids or family member has a high risk medical condition, again, we will not be able to admit, even though we have a staff, we have a nurses and doctor in the facility, but it's something that beyond our basic help, we will not be able to admit those clients as well. I see some questions. Okay, not, okay. I was just checking the chat. So I will talk about a little bit what the service components, it probably will be interested more for you guys. Triage, crisis response. Like I said, this is a brand new program. I kind of thought about this like 4 different stages for the services. First component is the triage crisis response. That's the first immediate response. So when we talk about the triage crisis response, what I'm trying to talk about is school counselors, law enforcement, police, parents. These are the people that our referral list. They may give us a call and then ask about our services. We have a first initial screening that we do either when they do walk-in or on the phone. So in the initial screening, we try to get the client's information, demographics, and basic information, insurance, and etc. And then we will be asking about the suicidality, any homicidal ideations, if they have been attempted any suicide in the past, what the method they used, what are the risk factors. We also try to ask questions like related to family, if there's any mental health issues, any substance issues. After the first initial screen, this goes to our electronic health record system. And the next day, the therapist or nurse will see, or the same day, it depends on the situation. If the call came in overnight and if there's no one to be able to respond, and they will call the parents and get the information, and they will invite it to the services. It's a little bit complicated, so I will say that let's think about this. When client and family, they came to our services first, they will be meet with the life skill coaches, which is they welcome, they get the basic information, they give them a handout, and then therapists will have the triage. So our therapists will do mental health evaluation assessment, which I included a couple of places here, which I'm going to talk about that in a little bit. What are the assessments we use? And then after, it's like, think about like a wraparound services. When the family and kid comes in, they foresee the therapist and they see the nurse, they see the psychiatrist, and they will be talking to the discharge person. This is all going on at the same time frame, like for the one client, be able to wrap around and see how we can help these families, what we need to do. Screening process. Talking about the pharmacy services. So when we are doing the whole assessments, we try to make a decision if the youth need a lower level of care, outpatient services, or they need a higher level of care. So not only one person, but the therapist, the nurse and psychiatrist and care coordinator, the family, they all make decision. But in that time frame, the kids already stabilized and de-escalated because we have two different rooms. We have chairs and we have family rooms. So if there is a situation that kid needed to be stay away from the parent, we will separate them. At the same time, we will be doing some deep relaxation techniques, maybe different things that interventions that will be stabilize the kids' mental health. At the same time, parent will be meeting with the therapist. After that, decision made, all the interventions, all the assessments done, and we try to use the right now evidence-based assessment tools because that's what have been required for most of the time. Let me see what's the next. Oops. So you will be mostly interested in the crisis assessment services and evidence-based treatments. We use crisis assessment. We use child assessment trauma screening, Colombia, PHQ-9, you guys are probably pretty familiar, but we use the PHQ-A for the adolescents because adolescents are different than the adolescents are different than the adults. They are not going to be able to verbalize and say, I'm depressed or I'm anxious. They're gonna most likely talk about, oh, I don't want to get alone, I don't want to go out, or I want to be alone in my room, or I do self-harm, I cut myself because it helps me and I don't feel the pain. So to be able to use the appropriate tools are very important to make a determination that what the youth and adolescents are needs in the treatment. Of course, like I said, the parents involved with the identifying issues and concerns is not only that parent or the child is presenting the issue and verbalizing. We believe in client-centered treatment. So even though in the crisis assessment, we try to identify what are the strengths, what are the positives in the youth life. Do they have some school teacher, or do they have a coach, someone that can be supportive? Do they are they active? Are they athletic? Do they write? Try to find some strength to be able to focus on that, to develop the coping skills, what they like to do. I mean, if the person likes to draw, we can say that, okay, why don't you express your feelings drawing a picture? Or why don't you increase your physical activities if you really like to play soccer or football? Trying to identify what the strength of the client. And the second or third stage, each child, each family has a different dynamic. Like I say, we focus on the client center because we try to find out what their needs, what they want, what's missing in the picture, what can we provide. Sometimes they need they don't have the basic needs, so we link them case management services. Sometimes they are dealing with maybe hopelessness. Maybe they need a shelter. Maybe they don't have enough nutrition. They don't have a therapist. They don't have basic needs to be able to meet. We try to identify those needs. And of course, when we are working, our organization doesn't work alone. There are several organizations in the community. We help each other. We have a referral. Everybody has their own roles and their own services. So we try to benefit with that. Like I work for the counseling and recovery services, but my unit, my program is, yes, Tulsa, but we have outpatient services for the children's program. So if we decided kids need outpatient services, they can be benefit from the programs that they don't need to be in acute services. We will do the linkage, we will do the coordination. So they will be able to, when they leave our facility, their psychiatrist appointment, their therapist appointment is already made and give it to them with their safety plans. Like again, during the treatment, after identifying the issues, main concerns, parents and kids sit down and do the objectives and try to decide, okay, what we need to do, what areas that we need to improve. Even though we are short-term stabilization places, we try to give them a general picture of what's the problem, what can you do, what are the sources, what can you do actively involved beside the therapist or psychiatrist. So we try to help with the behavioral side as well, that they can have some tools when they go back to community society, they can continue living functionally and less stress. Safety plan is very important when we are trying to discharge the clients. Safety plan, we try to include the safety plan with the parent. I'm not really sure if you guys are familiar or not, working in the crisis center. You don't want to discharge client without a safety plan, especially if they are high-risk clients. Safety plan is pretty much what are you going to do when you are in crisis. So we help client, youth, families, the triggers, like recognize what is that brought you to in that situation. Some people say that, yeah, I was stressed out already and I wasn't sleeping, I was playing with my cell phone, I didn't get enough sleep, and then I had an argument with my girlfriend, I got a bad grade from my teacher. It kind of lead it up. So try to help the kids see what are the triggers. And after helping them understand the triggers, we ask them, so, okay, what are the coping skills that you can use to eliminate these stressors? And again, we are not coming as authority. We are doing this as a collaboratively. We are asking them because we want them to come up with the answers. So as part of a cognitive behavioral therapy, sometimes we use a motivational interviewing, whatever takes to be able to help this clients to understand the real issues, the baseline issues. We will include this in our safety plan as well. Of course, when we are doing these services, coordination is very important. If the youth and family, they might have an ongoing psychiatrist, or maybe they have a family practitioner that help them prescribe medications. We sometimes have those situations too, especially the SSIRs cause suicidal attempt, like a high risk. When you start using, when you prescribe the SSRIs, first 2 to 3 weeks, a really high risk, immediate danger. Because when the person is depressed, when they take the antidepressant, they feel a little bit motivated to be able to attempt to suicide. So in that case, we will be talking about their prescribers. If they don't have any prescriber, we will be able to find them a in their own area, of course, need to be accessible, a psychiatrist in outpatient facility or services. This takes all the coordination as well. Making a decision is the most important thing. I think I already talked about, depends of the clients presenting issues. We will look at the risk factors. We will be looking at the protective factors. Okay, we are allowing this client the discharge. What are the risk factors? What are the protective factors to be able to make a decision? We do have 24-hour follow-up, like after client discharge. Are they satisfied? What's happening? Did they go to the inpatient facility or they show up in their outpatient facilities? And etc. So after a year, like I say, yes, Tulsa. The reason we say yes, Tulsa, everybody's name is Urgent Recovery Center. We want it to be different. We want it to be recognized. And since we are the first Urgent Recovery Center for youth in state of Oklahoma, we say, what will be catchy? We say, okay, why don't we say yes, Tulsa? Youth Evaluation Services of Tulsa. So URC service outcomes are pretty exciting and happy to see that. So far, we have been served 431 clients and families. When we were building this program, one of the requirements was we needed to show up that the program works and we will be able to lower the inpatient hospitalization. We will be able to do the interventions that will keep youths from diverting inpatient facilities, which I could say that we have been really successful because 365 clients diverted to lower level of care. They didn't have to go to the inpatient psychiatric facility. Only 75% of these clients diverted to higher level of care or residential facility according to their presenting issues or needed. So in our facility, when we look at the overall total numbers, the average length of stay is 4 to 5 hours, which is another biggest success because we have a limitation to discharge client 23 hours, 59 minutes. We cannot exceed 24 hours because if we exceed 24 hours, then the policies and producer and everything changes, we become an inpatient facility. So in that sense, we have been really succeeded. The goal was to be able to admit 90% of clients. We are getting there right now. We have been admitted 75 to 80% of referrals from our community. So that's pretty much, yes, Tulsa. Any questions? Suggestions? I probably went 100 miles an hour. I apologize.
Is there any question?
I like to ask, how would you describe the community, like profile? So what kind of clients or client issues?
Those presenting issues?
Yes.
Okay.
Are common, for example, because sometimes, issues are unique to the community. And so are they working, are they mostly from the working class families? Things like that, rural area or urban setting, like the income and like, education level, etc. in general.
Of course, we are a nonprofit organization. We accept clients with the insurances without insurances. So that help us. We provide services community if people they don't have any insurances. Like you were saying that clients that coming from a background that low incomes
Oh, okay.
or lower educational
Oh,
background. There are functional, dysfunctional families, but we are open to all because state already give us a funding. So services could be free for the community, for the people. That's the
okay.
greatest things about this program is accessible to everyone. If you have an insurance, you can use your insurance. But if you don't have any insurance, the state, the grant that we had $5 million from the federal government, we will be able to apply that to that services. Most of presenting issues that I will see right now these days, like depression, anxiety, eating disorders, PTSD, bullying, LGBTQ issues. A lot of young youths are experiencing trying to figure out their sexual identity, and especially in the United States, you know, it's a free society, and in that age group, they are wondering, what is this? What is that? Who am I? Trauma, and also, unfortunately, substance use. In the United States, I'm not really sure. I'm not very familiar with the right now the Turkish community. I have been away, but unfortunately, substance use, drug use, also among the adolescents are high. Like I said, they don't come and describe and say I'm depressed or I'm anxious. Parents really need to be, or the therapist need to be aware of the presenting issues and symptoms. The kids are they isolating? Do they decrease their activities? They may used to hang out with their friends, but they don't want to go out anymore. Sometimes they have psychosomatic system. Oh, I have a headache, my stomach hurts. They isolate. They don't want to be around people. They become argumentative. They could be fighting, temper issues. They might skip into school. Their grades could be lower. So when you are working with the youth, I think we need to be able to kind of aware of those presenting symptoms. Like I say, they are not like adults to be able to verbalize those symptoms directly.
Yeah.
There's a great group of people here, I see.
Yes.
Especially for the students. Any questions
I
you
have a
guys want to
question,
ask?
by the way.
Go ahead.
Is it hard to be a clinician in America?
Is it hard to become a clinician in America?
Yes. Is it hard?
It's definitely different than other states. So to be able to become a licensed clinician, you go several steps. So you get your bachelor degree. After the bachelor degree, you get a 60 minimum credit hours of master's degree from accredited university. Like I could say that my master's degree probably equal to PhD in Turkey, but not in here. So you complete 60 hours clinical work. And then after the 3 semester, 1.5 year, you work, you do like almost residential before you finish the program. It's called practicum and internship. After that, you complete your school. You're a mental health therapist, but you are not still licensed. So you need to work in an organization under supervision 2 years. You need to meet someone weekly supervision. And you take a test after the school, like overall the general exam. You have to pass and get a certain score from the test. And then you work
Very
on
long process.
It is, yeah, I know. So you guys are really lucky in Turkey. Like there are people, they finish school, they complete their 60 hours, grade 4,
Yes.
they complete their thesis, they do, but they cannot pass the test.
Yes.
So, but also, I mean, if you work hard, if I made it, I didn't grow up here. When I came to United States, I was 21 years old and I didn't speak word of English. I came to United States, 2 suitcases as a vacation to stay here 6 months. But if you have, he's laughing, Dr. Bulut is laughing at me because I came here for vacation. And then I've been here since 23 years. So the sky is the limit. If you work hard, if you have a motivation, sky is the limit, really. Like you can do anything you want.
Yes.
There are steps to complete, of course, but it makes you a better clinician. So, I mean, I highly recommend our young people to take advantage if you have opportunities to go overseas, experience, be in the different field, different experiences, that opens your eyes. But I see in Turkey also there are quite a bit of new opportunities are coming for the new counselors. Like I believe the school counseling and different departments now is opening. As far as I heard, there's a lot of opportunities in Turkey as well. And of course, there is a taboo is everywhere. The stigma to mental health.
Yeah.
Even in these Western societies, people are still hesitant. To answer your question, Ahmed, also, you have to be in therapy to become a good therapist. If you don't go to the therapy, they will not give you your licensure. Your supervisor will say, have you been in therapy? You need to go sit in that chair. You need to understand what it feels like to be a client, you can be a successful therapist.
Thanks for your answers, teacher. Is there any question? By the way, can everyone turn on their camera? I will take a photo. Please.
Oh, may I add something? Thank you for Solmaz for this wonderful presentation. We greatly enjoyed. She brought us new perspective. And our presenter from yesterday, Pietro, is here, I guess, in the room. And today is his birthday.
Yeah.
Yeah. Today is his birthday. Let's say happy birthday to him. Pietro, can you open your camera?
Oh, happy birthday.
Thank you so much.
Oh my gosh, happy birthday.
Thank you so much.
To you.
Happy
Happy
birthday to you.
Happy birthday,
Birthday to you, Pietro.
Thank you. Thank you so much. You're very kind. Unexpected. Thank you so much.
Where is the cake, Dr. Bulut?
We really like you.
He just went to bring it.
Yeah.
He wasn't
We take a rain check. How about that?
Good idea.
When is the next?
I was wondering, maybe a very short question. I was wondering, you said, federal government sponsors the center and you get funding through them. So do they have like certain conditions and limitations? So how do they regulate that?
Oh gosh, anything you get from federal government, you have to report. So we have so many different processes. So yeah, they will fund you.
But they will supervise every single penny.
I have to, my job is all day I go put a data. Did I go to school? Because I'm the program director, they do the work and I enter data. there is yes, federal government provide the services, but they want to know every client, the condition, what we have done, what's the results, what the discharge. There is a website that we need to enter all their informations to identify. And we also have, SAMHSA is trying to, of course, do research in this. You know, they are not just handing us it's going to be a lot of publications. There are questionnaires that they want us to give us a survey when the client come in, and we do the 6 months follow-up, like such as, where do you grade yourself, like hopelessness for the kids, like 1 to 5, like 1 is extremely, 5 is not, example, or school grades, different things. So they measure, they look at the program if it's working or not working. I mean, from accounting to everything we have to report. But we are thankful, you know, and I think it's a good measurement and keep people accountable, because, you know, we wanna show the services that we have provided. We want to be able to prove that what we have been come from, or what's the success rates. So they can also evaluate our program. We do meet with them. We meet people from Washington like once a month. Every 3 quarters, we have a report to give them, okay, these are the areas working, objectives, did we meet, not meet, so many different steps that they look for, which is, I think it's good, like keep us accountable.
I think that's very good for the accountability of your work, because sometimes when there are no such procedures are added, you don't know where the money may go. And if it is get to spend in a meaningful way or not, that can be a big issue also. So it's important that it is spent where it's needed to be spent, or where it is.
Yes, absolutely. And they don't like hand you, they give you like quarterly. They want to make sure that, you know, program is working, we are doing what we're supposed to do. And they also have requirement, like there are certain trainings that we have to go through, because we have a different level of clinicians. We have the mental health therapists, we have the social workers, we have a mental health tech, we have coordinators. So each clinician need to be able to intervene the crisis. So they go to the trainings. The good thing is they, you know, trainings are provided, but they ask us to.
Yes. Yes, thank you so much. I benefited a lot. We appreciate
I have also a question.
Yeah.
Go ahead.
What is the popularity of counseling or psychology in America, and how is job market right now, nowadays?
Oh my God.
Finding a job and being counselor in terms of like job market, is that easy finding a job?
Let me tell you, it's incredible. When I graduated 20 years ago, there will be a couple of jobs and 10, 15 people will apply, and they will pick only one. Right now, there is so many jobs, so many opportunities. We cannot find enough clinician. I have an opening to hire for a second therapist.
I will come.
Huh? You will come?
I will come. Yes.
So I've been trying to hire a second therapist because the numbers are increasing. I need to cover overnight. It's been 9 months. Nobody's applying. Can you believe that? Market is so comparable. Nurses and therapists are high demand, and in the United States we don't have enough people. Yeah, it's unbelievable. Like I said 20, 30 years ago when we apply, right now I'm just looking at anybody to send a resume so we can hire. Unfortunately, there is not enough clinicians. So there's a lot of opportunities. I mean, if you guys are, I see that you speak well English, you understand English. I will highly encourage you guys to apply some schools in the US. There are a lot of graduate assistantship, there are teaching assistantship programs. And they are looking for a lot of people from diverse backgrounds too. So that's a plus. Because in psychology and social sciences, mostly in hands of Native, like Americans. The international students or people from international background, they don't study social science. They go to engineering, IT, computer science, mechanical engineering, and etc. So in the social sciences, they need more diversity background. People are from international background, African Americans, Native Americans, Asian descent. It's really hot subject needed.
Yeah.
Is there any question?
I think there is one.
Probably no. Any question?
Hi. I'd like to ask one question, if we have time.
Of course, teacher, please.
Okay. Thank you for being with us. And thank you for a nice presentation. You talked about parents, families, and disadvantaged families. And also you mentioned family volunteering. Would you please give some more information about what kind of work you do with families? Do you do like education or psychoeducation? How you cooperate with families?
That's a great question. And I really appreciate you bringing that, the subject. Our program, like you said, is a family model, and especially if they are coming from disadvantaged families, we have a care coordinators and case managers. They help, they do psychoeducational, like how is the parenting, what missing. Sometimes they don't have the basic skills or basic knowledge to understand, like, okay, what is timeout? What is setting boundaries? What is encouragement or reframing or doing basic things that usually educated families has the knowledge. So part of the program that educating those families, helping them to understand their shortcomings. Yes, it's a great question. Otherwise, it wouldn't be a family base because, like I said, it's most of the reason the kids are there because they are experiencing something at home. This could be traumatic events or a mental health issues or substance health issues or poverty. There is something going on at home that not been addressed appropriately in the past. Doing this intervention and educational program will prevent youths to develop further severe mental health issues. And most people who has been traumatized, whoever the traumatic person, they have been traumatized themselves. But unfortunately, they don't have enough knowledge or skills to be able to recognize. And it's so sad. We see kids are with the substance abuse issues, parental abuse, neglect. Some parents, they don't want to be part of it, or divorce, single parents. The mother is working 2 jobs. basically don't have any time. There's no communication, no interaction. Sometimes people are so busy working in the world field that they don't recognize. We even tell them, parents, like the basic things. Have a 10-15 minutes. Ask your child, your youth, how was your day today? What did you do? What did you learn? How are you feeling? Like those basic things that normal parents will ask or have a communication. Some people don't. But thank you so much. That was a great question. I hope I was able to explain.
Thank you. Thank you, Naime, teacher. Is there any question? Probably no.
Are we going to take a little break before at Jacob's?
Yes, please. That would be very nice. We
Okay.
will meet at 7:30. I ask the friends and student and faculty member come and join us again. Ed Jacob is a wonderful person. He is going to talk about impact therapy.
Yes.
It's a great opportunity to listen to him. Probably we all need break, right? And also thank you.
And
We are honored to see you, by the way, Ms. Solmaz. Thank you for
sorry.
all presentation.
And students or attendees, they don't need to log out. They can just remain, stay here, okay? And just come back when it is like 7:30. We'll start a few minutes before for the introduction. So please be on time for the next session. Thank you so much for talking to our students, joining our Global Guidance and Counseling Congress online webinar today. Ms. Solmaz Bulut, we appreciate your time. I'm sure our students benefited a lot. They enjoyed your presentation. Thank you so much.
Thank you so much. It was my honor to be here, and I had a really great time. Thank you so much.
Thanks for your all presentations. We are
Yes.
nice to meet you. We
Good
are
luck,
honored to
guys,
see
for
you.
the future. Bye-bye.
Bye.
15 minutes break time. Our second session going to start 7:30. See you.
when are you going to Pritikin?
July 23rd.
Well, can you do Chicago June 22nd?
Come on here. I'm going to Chicago on one in July, but I could do a night. Yeah, I've got an 8 to 10.
Dr. Jacobs, hi.
Out of this. Okay, well, I'm gonna call you back. I'm back. I'm on this turkey stuff. Okay.
We still have 10 minutes. If you need, you can go.
Oh, no, that's okay.
It's wonderful to see you.
Oh, yeah.
I'm very pleased to have you here.
Well, I'm excited to do this. Like I said, I'm gonna have one former student from Turkey.
Okay.
And then one current student that is currently, and they can, because these are undergraduates for the most part, right?
Yes.
Yeah, and we'll just tell them what impact therapy is, and
Yes, you can do a brief introduction, maybe give some samples, maybe teach them a couple of techniques that they can use.
Oh yeah, it'll be good, I promise. Yeah.
We will start at 7:30, but we have great friend here. There are some faculty members. We have Nadire Gülçin. Probably you can see on the screen Nadire Gülçin. She's gonna come. She's co-partner with me.
Okay, yeah, she's been in touch with me too.
Yeah.
Right.
Yes, she was. And Naima Doğru, she's my partner at my school.
Oh, okay.
Hello.
Hi, how are you?
Thank you. How are you?
I am good.
Nice to have you here.
Oh, glad to be doing this. I thank you for having me.
Yeah. We have Pietro from Italy. He was presenting yesterday. Pietro, are you here?
Yes, I'm here.
Say hi.
Hi.
And we have Pietro. Hello.
Hi.
Thank you not leaving us. You stay with us.
Yeah.
Yes, I stay with you.
Okay. Ed Jacobs from West Virginia University is presenting today. And we have Afifa from Pakistan.
Oh, okay.
Afifa from Pakistan. She's also faculty member. And I have my student, a couple of undergrad and graduate student, and two universities jointly we are organizing this. Some of them are my students, some of them the other university. My university is Ibn Haldun University, Counseling Psychology Program, and Medipol University Counseling Psychology Program. We have undergrad and grad student, a couple of grad students as well. I really encourage the student, please, can you open your cam? That will be more personal. We feel more close if you can open your camera.
Yeah, I'm gonna tell Cassidy they can get on now too. What to say?
Ahmed is here in the corner. Ahmed is the chair of this Zoom session. He's the boss here.
Thank you.
But get Chala.
By the way,
yeah.
By the way, welcome, Professor.
Hi.
We have Büşra, we have Abdullah, we have Niyazi.
We're doing some work with some people in Turkey at this university on the eastern side or something. Chala will tell you about it.
Okay.
We did some training. They want to do some impact therapy. We spent about 6 hours talking to them, and they're going to try to do impact therapy in their school.
Okay,
So,
wonderful.
2 people entered the waiting room. Okay, Cassidy. Cassidy is my student.
Hello, Chala.
Chala.
Hey, hello, good afternoon, or yeah, good evening there, I guess.
Good evening.
Yeah.
Cassidy, hello.
Hello,
Thank
everyone.
Hi, everybody.
Thank you coming and joining us. Thank you being part of this small project. We are very excited to listen to you. We have a few minutes.
Would it help if Chala did hers in Turkish, or does it matter?
We will go in English.
Okay.
Yeah.
This program is in English.
I can't, Ed, I can't process Turkish.
Okay.
I just gotta stick with one language, so.
Okay, that's good. And
Okay.
Nadira Hoca, she came.
Yes.
She is also a chair.
Yes. Hi, Professor Jacobs. So, welcome.
Thank you. And these are 2, one is my former student, Chala, and one is my current student, Cassidy.
Who is your current student?
Right here. Hi, I'm Cassidy Seal.
Oh, okay, wonderful. Wow. Awesome.
Yeah.
Very good.
Hi, Cassidy. Nice to meet you virtually.
Hi, Chala. Good to meet you too.
Welcome, Cassidy.
Chala, what university was that we were working with?
Atatürk University. It's in Erzurum, Turkey.
Mm-hmm. What did you do there?
They reached out to Ed to do like a impact therapy training. So we did 2-day long, kind of very comprehensive workshop for them to learn more about impact therapy, the theory, how to implement the theory during their session. So basically a very extensive impact therapy training where afterwards we had them submit videotapes to role play and apply different techniques that they were taught during the sessions. So that's pretty much it.
Because they want to, they're going to put that in the curriculum, right, Chala?
I believe so, yes. And because it's very important to have certifications in Turkey showing that you have received XYZ training in different approaches and theories. They wanted to be certified in impact therapy. So At the end, once we complete the training totally, they will receive some sort of training showing that they have been impact therapy trained.
Did you train faculty members or undergrad, grad students?
Both.
Both grad and
They weren't undergrads, were they?
No, I think they were all master's level and above. I believe
Mhm.
there were some PhD students, some master students. I'm not sure if there was any undergrad. I'm not going to
I don't-
speak to that,
yeah.
but there were two also faculty members. One
So
that
this is your requirement. You go and train them, but also you ask them to prove some work like role playing and CV, DVDs, records, etc. Is that true?
are you asking me or Ed?
Well,
To
both
you.
of us, since you and I are the training, we're the training institute. Yes, we would, if they're gonna do it, we just had to make sure they got the concept, because I've trained people, some people have come and worked with me, and they really didn't have the basic understanding, but all the tapes, Chala and I listened to them, she translated for me, and it was impressive. I mean, we were real impressed. It was way better than we thought it would be.
Oh,
Yeah,
Yeah.
I was very proud, I will say. They did such a great job, but officially, that's not my role at all. It's just that the group happened to be from Turkey. And when Ed asks for a favor, I'll do it. So it's more like it's not my official role necessarily. It's just the relationship we have. And if he asks me to help with something, I will do it. It's not that I'm a certified trainee for impact therapy or anything.
But Chala, we met, was it 10 years ago?
10 years ago, Ed. Can you believe
Yeah.
that? Exactly
Yeah.
10 years ago.
Because I did a presentation in Istanbul at her university.
Yeah.
And she was our guide, and then we got caught up in the riots that were taking place.
Gezi Park olayları. That's when he was visiting. So we got stuck for like 24 hours in Taksim because that's where their hotel was. So we got caught in the middle of it.
oh,
And so then she came and studied, got her master's, and then she's got an MBA, and she's going to go on into a doctoral program.
Yeah.
Or what is it? Organizational development or?
Organizational behavior and human resource management at University of Pittsburgh.
Okay, but what is your undergrad degree?
Psychological counseling and guidance from Marmara University.
Okay, wonderful.
Mhm.
very impressive. Very good, Chala.
Thank you.
Yeah. So, should I start with the introduction, Dr. Bulut? Okay.
We can start, I think.
Are they going to put their cameras on or off?
I think it's optional.
You can share your presentation, Professor.
Okay, I'll do a little introduction
Okay.
before we get started. Okay. Welcome to the first Global Guidance and Counseling online webinar. I have the pleasure to introduce you today, Dr. Ed Jacobs. He's a professor in counseling psychology and rehabilitation department at West Virginia University, where he has taught for more than 30 years. He currently is serving as the coordinator of the master's program in counseling at West Virginia University. He also is the founder and director of Impact Theory Associates, which offers private counseling and 25-30 presentation per year. Presentations are often 1-2 day workshops, 3-hour programs at national or state conferences or keynote addresses to state conferences or large organizations. Dr. Jacobs was a national presenter for the American Counseling Association. Dr. Jacobs has written 6 books: Impact Therapy, The Courage to Counsel, Impact Therapy, creative counseling, and illustrated guide, group counseling, strategies and skills, group counseling in correctional setting, and how to select and apply change strategies in groups. He completed his undergraduate and master's work in psychology at the University of Texas in Austin, and his doctoral work in counselor education at Florida State University in Tallahassee. He currently teaches graduate courses in counseling techniques, counseling theories, group counseling, addiction counseling, crisis counseling, grief counseling. Dr. Jacobs also supervises the students who are in practicum and internship. In the past, he has taught marriage and family counseling, counseling regarding sexual issues, advanced techniques, and adolescence and adult counseling. Dr. Jacobs has served as an ongoing consultant with different school districts and drug and alcohol agencies. In the summers, for a change in scenery, he often teaches at other universities in the United States. Dr. Jacobs also spends considerable time mentoring and working with the associates who are offering impact therapy throughout North America. Dr. Jacobs was selected as a fellow in the Association for Specialists in Group Work and also received in 2023 the Professional Development Award from that association. Thank you so much for being with us today.
Well, thank you for having me. I realize that biography is a little old because I've been there 50 years now instead of 30, but who's counting? Let me tell you what we're going to try to do for all of you today. Since you're undergraduates, I have two of my students, and they'll introduce, one's a former student, a woman from Turkey, and she'll introduce herself in a minute. But let me tell you what we're going to shoot for. We're going to try to introduce you to an approach to counseling called impact therapy. And there's no one on the planet that likes counseling any better than I do. I've been doing it obviously for a long time, and I could be retired, but I still love doing this. Cassidy, who'll introduce herself in a minute, she's someone that I'm mentoring now. She's in our program. Chala is someone I mentored and met in Turkey 10 years ago, and she'll tell you some of that. But I created impact therapy in the early 1990s, and it's an active approach to counseling, because I think what I saw and what I learned in my programs is sort of a more talk, listen, boring approach. And I thought that could be more to counseling than that. And so we're going to show you what impact therapy is. I'll get Chala to introduce herself, and then Cassidy. Then we'll tell you a little bit about what impact therapy is. And then we're going to show you some different things. I'm going to give you one tip or one hint or what it is. It's an idea of being multisensory. So if you have an angry client, instead of just talking to them, you can shake up the Coke bottle and say, here, open this. And that tends to get their attention. So one of the things about impact therapy is talk to their eyes as well as their ears. And that's what we're going to be showing you. I don't think it'll be boring. We've never been accused of being boring. Chala, you want to tell them a little bit about you?
Yeah, absolutely. I kind of gave you all the preview, but I obtained my bachelor's degree in Marmara University, and I studied psychological counseling and guidance there, and I graduated in 2013. Shortly after, I worked as a school counselor in Fatih Hoca Elementary School in Beykoz, Turkey, or Istanbul, Turkey, I guess. That's when, right before I graduated, I met Ed. He was visiting Turkey on a workshop that he was going to conduct, and I was really into his books, and I loved his therapy. I had been a big fan of his back then, and I still am. We were introduced during that visit. Then I came to United States, West Virginia University, to obtain my master's in counseling. shortly after I obtained another master's in business administration, because I wanted to take my knowledge in psychology and counseling and apply it in a more industrial setting rather than clinical. And after graduating with both masters, I decided to pursue career counseling rather than the clinical route. And I still apply impact therapy principles, not only in my work as a career counselor, but also in my daily life. In August, I will pursue my PhD in organizational behavior and human resource management at University of Pittsburgh. And I can guarantee you that, again, the teachings, the theories, the techniques that I learned in impact therapy, I will take with me. That's a little bit about me. I'm going to leave it to Cassidy.
Yeah, hi everybody. I hope that you're doing well. I'm Cassidy. As you heard before, I'm a current student of Dr. Jacobs. Just wrapped up my first year in my master's program in clinical mental health counseling, and I've helped with a couple other impact therapy presentations, and I've learned a lot about impact therapy over the first year, and we'll get into that, but it's great, super exciting, and I'm happy to be here to help where I can.
Let me, Chala, what drew you to impact therapy? Why were you drawn to it? Because you were studying, and then what? Yeah.
Well, at the time, I was one of the few English speakers in my cohort, and my professors wanted me to translate some chapters to teach in class, and because our program was in English. And I was reading and I was like, oh my God, like this is actually very hands-on and very, very interesting. It's not boring, it's very engaging. And I started to do a lot of readings and started watching your videos. I think the main thing for me was that in Turkey, I think, at least for Marmara University, I can't speak to other schools, but the theoretical teachings is very strong. They do a very good job of teaching you the theory, the techniques, but when it comes to application of those things, I was really falling short. I didn't know how to take everything I learned in class and apply it in a kind of in-person clinical setting when I was counseling clients. So impact therapy bridged that gap for me, where it kind of gave me the courage to make it more interesting, pull up the chairs and, you know, talk to them about their script. And it was very hands-on, and that's why it really stood out to me.
Let me say a little bit about what it is, what impact therapy is, because most of you, I would think, have not heard of it. And you can go on YouTube under my name or under impact therapy, and you can watch a lot of clips. But it's an active, creative, multi-sensory approach to counseling. And it's more than talk, listen. Most people think of counseling as a talk, listen process. And in impact therapy, we do more than that. And I'm going to give you a couple of examples, and then I'll let Cassidy just talk about how, you know, it was surprising. I know she said this before to me, just how it was to learn what she's learning was different than what she thought she would learn. Here's the way to think about it. What profession knows the most about change? It's probably advertisers. And they use damn near anything, right, to get you to change. But we teach counseling in this sort of boring way of you reflect and you do all this, instead of, why not add like a rear view mirror? You got a lot of clients that are looking back. So if you hold up a rear view mirror, get them to hold it up and then talk about the idea that you got to stop looking in the rear view mirror. And you can ask them the question, why is the rear view mirror larger? I mean, why is the windshield larger than the rear view mirror? Because it's your future. Advertisers know people remember images. They, you know, not just words. But when I was in school, I just learned words. And then I stumbled on a guy that was doing transactional analysis of theory, where they talk about the parent, adult, child, and that was visual. And then I stumbled on Gestalt therapy that had that empty chair and the idea. So what we're saying to all of you young people, it does not have to be a boring profession. It is not boring. And here's one other phrase, and then I'll let Cassidy make some comments. The brain likes novelty. That's a given thing. It does. And so any way that you make counseling novel, that's what advertisers do. So that's what can make counseling better. And it also prevents burnout because it makes counseling fun and creative instead of locked into a box of just doing it a certain way. Cassidy, you want to add some thoughts?
Yes, absolutely. And I remember back when I first started and Dr. Jacobs first introduced impact therapy to our cohort. And I remember being very surprised because he'd pull out the props and I would think, well, what's going on? Because I'd personally never been in a session or a therapy session where a therapist had used props. It had always been talk, listen. So I think at first I was not a believer, but as he taught more about it and we practice more, you really get to see the impact that it does have. So I mean, truly give it a try. You get to see the engagement goes up, the energy can shift, like your sessions are going to be a lot more energized than just sitting and doing the talk and listen, which is important too, but you want to put that energy in, which impact therapy really does. Yeah.
Yeah, the phrase that counseling should not ever be boring. And there's a lot of counseling, and some of you out there that we're talking to, I'm sure some of you have been in counseling, and some of you've had good counselors, I imagine, but some of you've had some bad ones, or you didn't know. But because what's really sad is I have people come to me and they say, I got more out of the first session than I did 6 months with my other counselor because all she did was listen to me. And so, and some people that you're trained and it might be hard to let go. As undergraduates, you've probably not been trained so much, but a lot of people at the master's level and beyond, they think there's a certain way to do therapy, like Cassidy's saying. At first you thought this isn't right, but then, and you don't use the rearview mirror to be cute. You use it because that client keeps coming in and talking about their marriage. They're divorced now. You got to stop looking in the rearview mirror. Now they'll remember that phrase probably in the picture of the rearview mirror. So that's what impact therapy is. And Chala, you use different things in your career counseling stuff.
Oh yeah, I always use RCFFC, the map, to channel my sessions. I'm sure you're going to talk about it here in a second. Whenever it comes to career decision making, parents are very much involved. So that's where I use a lot of TA, a lot of chairs. I hear a lot of the child speaking when it comes to these college students, when it comes to choosing a major and a career. And I always remind them to, use sentences from their adult ego state rather than being in the child and not getting caught up in the drama triangle or the infinity when it comes to their arguments with their parents. I do use it all the time, and not just, again, career counseling, but in my own life too. These are beneficial not just in your professional settings, but also in your growth as a person.
Since we're on Zoom, this is what we use. In Cassidy and I do a lot of co-counseling together. She's got the same props, sort of. So, but the idea, what she's talking about is a lot of times people are in the little chair, the little boy or the little girl, and they got to sit in the big chair. We've got a guy that's afraid to ask women out. He's got a coffee, by the way, with Lily on Wednesday. So, but what happens is if you're in the little chair and then you move to the big chair, or Cassidy, you have your small chair there too, the regular one. Yeah, see, we use that chair. That's a small little touch chair, and it has an image because that's what a lot of people do. They sit in that chair and it makes a difference. And that's what Chala is talking about. A lot of people trying to make career decisions from the little chair, and you say, we got to get you to the big chair.
Yeah, I don't care what my parents say. I don't want to be a doctor, or I want to be this. I don't care. Like that childish kind of attitude, you focus on their sentences and make associations with the little chair and point out the fact that this is where you're sitting right now. This is who is talking. What do we need to do to make sure that you move into the adult chair and kind of speak from that terminology, like those kind of, mindsets and sentences, I guess.
Chala mentioned the RCFFC, and I'm going to just mention that and see if Cassidy, you want to add a little bit. That's a map. If counseling should follow some sort of map, otherwise you just follow the client's story. Mm-hmm. So we have a map in our book. RCFFC is rapport, then contract, then you focus, and funnel, and close. Rapport, contract, focus, funnel, and close. And that's what Chala said. She follows that map, because if not, you're just all over the place. And a lot of counseling is all over the place because the counselor, he or she is not following a map. So that's one of the maps. The other one that we're not going to get into in any big way, and this is for all of you out there that are going to study counseling if you go into it, there's all kinds of counseling theories. And you cannot be good at this unless you drive your sessions with theory. So impact therapy is not a theory, it's an approach, but it's theory driven. There's a lot of theories that it's built on. And so that's what I would urge all of you to do if you go into this field. It's a wonderful profession if you're good at it. It's not so wonderful if you're not, because it drains you. You hear all this people's pain, and if you don't have theory, you don't know what to do with it. And you go home at night, feel bad because you didn't know how to help. I've trained Chala and Cassidy. They know what to do now with their clients. You want to add anything?
Yeah, just on RCFFC. I think when I first started, I thought that rapport needed to be the whole first session or something. That's not necessarily true. And you of course, you want a certain level of rapport because that will enable you to do some good counseling. But once I got more confident in my skills, but also utilizing impact therapy, I realized that contract and focus and funnel could come a lot quicker, and rapport didn't need to take so long. And that's when I started to become more effective as well. So having that guideline is great.
Because what Cassidy would do, I gave her a couple of real clients because she stood out in my class, and I thought she was ready to have real clients, but she had a talker, and that woman would talk her ear off. I mean, just talk to her. So then she had got up the courage to cut her off or interrupt, and it was much more effective. So that's those are two maps. If you go into this field, make sure you have some map you're following that takes you through the process of counseling. If you don't have one, we urge you to just use this RCFFC. The other one is theories, and there's a bunch of good theories out there. We're not going to try to sell you on any one or two or three, but make sure, because this is something, I'll let Chala and Cassidy talk about this. Always in that first class or the first techniques class, we start talking about listening with a theoretical ear. What did that mean to you, Chala, when you heard it? And then what does it mean to you now? Do you remember that?
I do. So, like I said, my theoretical background was very strong from my education, but I never knew how to put that in application. So whenever I was in a session and my clients start saying stuff like, I should not be this, I should be that. And I start hearing, oh, this person has a lot of shoulds. And that's the REBT, like that's the kind of theory and the technique. And the moment I hear that, my brain immediately started thinking in terms of theory. And I'm like, okay, if the person has a lot of shoulds, this is how I help them. This is how I point out the fact that they have shoulds, versus in the past, I would just listen and listen, maybe reflect. Oh, it sounds like it shouldn't be done that way. Oh, okay, I understand. And that wasn't necessarily that much effective, because these people come to you with the hopes of changing their behaviors or wanting to see change. And the change doesn't usually happen if you are passively engaging in the session and not actively, apply the techniques and theories that you learn. So that's what it was for me. Or for example, I knew what Gestalt theory was, and I knew that they use chairs. But the idea of hearing someone from different theoretical, or not theoretical, but ego states, and then having the courage to pull up the chairs and be like, this is how you apply the chairs. I hear that you are coming from your child, from your adult, and here's what they look like. And kind of pulling those chairs, I think, gave me the courage to make it more applied and hands-on.
What about you when hearing that Cassidy was about listening with a theoretical ear? What did that mean to you in the first semester? What does it mean to you now?
Yeah, in the first semester, it definitely felt more intangible. Like I knew it was not something that I had yet, but everyone assured as I learned it would happen. And sure enough, it did. It was my second semester when we got more into theory and we really started practicing and using it, because it's not, I wouldn't say it happens naturally. You have to practice with the different theories to hone and develop your theoretical ear. And I'm still, of course, learning about my theoretical orientation and what feels right. But now when I am practicing in classes or with the clients that Dr. Jacob supervises me with, it comes a lot easier, like when Chala said, when you hear that language of they should do this, or I want this, I need, like, you can do transactional analysis, REBT, like when you hear that language, and all that comes from practicing theory.
And if I might add the noise. So as new counselors, you will have that noise in your head, the noise of, okay, the client's talking to me, they're sharing some very intimate details. How do I help this person? Constantly you're thinking, how do I help? What do I do? Listening with the theoretical ear helps with that noise, helps reduce that noise, because you hear phrases and different theoretical things from the client, and you immediately in your head kind of come up with a map of, here's how I help this person. So you kind of reduce the noise and start being more present with the client in the session.
Cassidy, tell the story of your voice. And yeah,
I knew that was coming next. When I first started, one of the biggest hurdles for me was my voice, because in a session you want to be authentically yourself, but I was just putting on this persona of a counselor that you'd maybe see in a TV show, and I did not sound authentic. I did not sound like a real person truly. And once I got past that hurdle, which took practice, counseling became a lot more fun because I was being myself as opposed to this person that I thought maybe a client would want to hear and talk to.
okay, so that's some of it. And we're going to do about another 15, 20 minutes and then let y'all ask us questions and things like that. I'm going to talk about different props, and Chala, you and Cassidy can think of some too that you might want to show.
Yep.
Everybody in counseling should have a toy hammer, right? Because don't clients beat up on themselves? So you just, say, here, take this, because, whack yourself in the head or something. And they remember, and you talk to them about how they have to put the hammer down, because that's what you have is clients that are beating up on themselves for mistakes they made, and they just keep beating up on themselves. You got to put the hammer down, learn from it, but you don't have to keep beating up on yourself because it does you no good. And that visual image is a very good one.
put the hammer down, beating up on yourself. I think there's a language gap there. I think in Turkish it could be dövünüp durma. Dövünüp duruyorsun sürekli. Kendi kendine dövünüp duruyorsun. Hani o noktada that's when you can bring the hammer. It's beating yourself up, putting the hammer down. It's an English kind of colloquialism. It may not exist in Turkish, but dövünüp durma would be the kind of actual Turkish reciprocal of that phrase, I will say.
Thanks. You need a shield and a filter. And you know, when you're doing counseling, a lot of clients, they need to filter stuff that's coming at them. And if it's real bad, when they go home at holidays or they got an alcoholic parent or somebody, they need the shield. And then you talk to them about they've got to block that out, because if not, you know, they just take on all that negativity that's coming at them. So blocking, and I've done it where I've thrown ping pong balls at the shield. And it gets what you want to do. Here's what all of you out there want to think about is you want to have your counseling sessions be memorable. And that's why these use of the props can help make them memorable. Either one of you got one you want to do, talk about? I'll keep going.
You keep
Okay.
it.
But we'll do the chairs here in a minute. The use of fuses, you have that's a long fuse. That's a pretty long fuse. This is a short fuse. That's still a short fuse. You talk to people, you have all kinds of clients, and some of you there, you have short fuses. And what you want to do is get a longer fuse. We tell this story, this third grade counselor, she worked with a little boy, a little third grader, and she told him he had a fuse problem. And she told him what it was. And then 2 days later, there's a knock on her door, and there's the little boy with two boys behind him. Miss Imperial, they have a fuse problem. Can you help them with their fuse problem? It stuck with him, and it'll stick with clients that, you know, your life isn't going to work if your fuse is this big. And some of you out there have an anger problem. I hope you'll get it taken care of, because that you know, it's no fun to be blowing up on people.
Culturally, I struggle with the fuse analogy too. So for my Turkish people, maybe think about whenever you are dealing with anger management issues with a client, think about a candle, mumun o şeyini düşünün, ipini düşünün. And the fuse that he's saying could be the candle's, you know, length. The longer it is, the less it's going to burn the candle. The shorter it is, the candle is going to start burning immediately. So instead of the fuse, maybe you can think of the candle. I don't know the Turkish name for the rope.
Wick,
I guess.
Right? That's what it is. Okay.
Fitil
let me
de bir
do
şey olabilir.
Evet, fitili. Aynen, mumun fitili.
If you got clients where they're talking about their self-esteem and say this represents your self-esteem, and you've got holes in it. I'm not pretty enough. I'm not smart enough. I'm not good at sports. And then you have all these holes, or my dad doesn't, I don't know who my dad is. And then you ask them, well, this is why you don't feel good about yourself, because you have all these leaks in your self-esteem. And so each week when you come to counseling, we're going to work on plugging the holes. So these are some of the props. And we have a book called Impact Therapy, and it is translated into Turkish. So you can.
It is now.
Yeah. Yeah, well, it's been out for a while, right? Yeah.
Like 2013 when you came.
So we're going to move on to some other things, and then y'all can ask us a lot of questions if you want. The use of chairs. Cassidy, how have you used chairs in your counseling so far, and what are your thoughts about that?
Yes, in a lot of different ways. When it's over Zoom, you kind of have to alter the way you do it. But when I practice in person, you can pull up multiple chairs, extra chairs into the session, have the client move, say maybe there's a perspective of maybe they don't know if they're going to move yet, if they're going to take the job in the new city. And then like that's one chair. And then the other chair is I've decided to make this decision. I'm going to move, take the job. And you have them switch back and forth, talk to the different parts of themselves. But over Zoom, which is where I've used it the most really, is I'll use my different chairs to talk about transactional analysis. This is the child's chair. This is the adult chair. And I'll use this as the parent chair. If they have a really big child, I'll use like forced perspective. So like, this is your child chair right now, and this is your adult, how it's like smaller. Or if they have a really big critical parent and small adult, and you can do, and it's really intuitive when you're working with people over Zoom. They're like, yes, I am in my child right now, like that is my child and this is my adult, and we want to switch those. I also have a client who something that's really valuable for them is talking to the child chair. I'll just put this and I'll be like, hey, this is your child part who's saying like they don't love me because they didn't answer my text or something like that. And I'll have them be like, and where you're at is your adult chair. Talk to this chair from your adult. And that's always really valuable for them because they can hear themselves speaking and they process it better that way. But really, there are so many different ways you can use chairs, just a million different ways.
Well, and that's what we want to say. What a lot of counseling is, if it's talk, listen, and it's a Carl Rogers approach, if you're from, that's a theorist that you might learn about. All you do is sort of, it's a vague experience, and where the chairs makes it concrete. If you simply say, look, you're currently in this chair and you're trying to move to this chair. What's keeping you? That helps the brain by making your counseling visual, as well as, it should be visual and theory driven. None of this is meant to be cute. It's just meant to be helpful. So there's chairs, and then there's a theory in counseling called Gestalt therapy, where Chalo had mentioned it. That's where you put your dad in an empty chair, or you put your mother or whoever you might have unfinished business with, and you talk to them. It's a very powerful experience. And none of you will try to practice that, and you don't do it unless you know what you're doing, because I mean, what it does is it's somebody, Cassidy can be talking about her mother, and then I just say, here, what would you say to her? And then all of a sudden, because you're putting it in the present, people break into tears. I'll tell you just a funny story. I had a student that had to make a tape, and he was doing it with his girlfriend, and he was having his girlfriend said, let me make, she got into some heavy stuff. And so he was there and said, let me pull up this chair. He pulls up a chair. She starts talking. Then she starts crying very heavily. Well, then he starts rubbing her back, which is a very appropriate thing for a boyfriend. It's not an appropriate thing as a counselor to be rubbing the person's back. But it was just funny because he didn't expect that much emotion. But Gestalt therapy, a lot of emotion can come out of that. And those of you that if you go in this field, there's some wonderful theories. I mean, and just know that, and you have an opportunity now. I think you have access to pretty much the same videos that we have. You can watch stuff on any of these theories. You can watch probably for 10 days. I mean, they just have stuff on the internet now on YouTube. Any thoughts on you, Chala, on the chairs? Just you want to add?
I don't want to necessarily add to the chairs or the Gestalt. I think you did a really good job, but maybe we can talk a little bit about REBT because it's such a core in impact therapy, and maybe we didn't do it as much justice as some of the other theoretical approaches.
Well, let me just briefly do REBT or CBT will be the thing you'll hear about. REBT is a form of CBT. CBT stands for cognitive behavior therapy. REBT is rational motive behavior therapy. It's one of the top 2 or 3 theoretical approaches now. That is based on the principle, and it's a principle that I say it's the most important. It's the single most important thing I've learned in my professional career, and that is that thoughts cause feelings. That if you're angry or you're guilty or you're jealous, it's what are you telling yourself that's causing you to feel that way. And it lends itself to chairs because a lot of times people are in this chair telling themselves something like, I'm never going to amount to any, I'll never get married because I'm 23 years old and my boyfriend broke up with me. And I say, that's this one, because that's not rational. That's the self-talk going on in the person's head is different than self-talk that's in the adult chair. So we tie a lot. There's a theory called transactional analysis, or TA. Those 2 theories are very important theories that we use in impact therapy because they're visual. They can be made visual. Okay, we've got about 6 or 7 more minutes before we'll take your questions. And hopefully you'll have a bunch of questions for me or for Cassidy or for Chala. Writing. Let me talk about writing and then I'll get them to talk about it. Why not write things or have your client write things? Or if you watch on YouTube, you'll see me with a big whiteboard. And we make a list of things. Talk to your client's eyes as well as their ears. That's the message. Because what we tend to do with talk listen is just their ears. But if you make a list of characteristics of what you want in a boyfriend, and then characteristics of what you've got in a boyfriend, and that's up there on the board, and they look at it. I had one client, she looked at it and said, that's pathetic. Because she knew that what she had was not what she wanted. And that visual list on the board is very helpful. Y'all want to add some? I imagine, Chala, you use writing in a variety of ways.
Oh, I do, definitely. And not just, again, in career counseling, but in any, aspect of my life. But if there are really painful things that, or even impactful things that you're trying to communicate with the client, like grief, for example, write it in big letters and put it in front of the client's face. So you can't see anything but your grief right now. It's okay for XYZ time period, but when are we going to get you out of this? So writing is very powerful. It really engages another sense. So that's why we say that impact therapy is multisensory, because it's not just for the ears, it's for the eyes. And it really stood out to the group in Atatürk University when we did the training for them. In their videotapes, they did use a lot of writing, like having a whiteboard behind you, like in the session, and write it down as you talk about certain things, or even a piece of paper. And that really gets clients going, kind of seeing things visually as well as hearing them.
Cassidy.
Yeah, absolutely. I also use writing just a ton. And on top of it being engaging and impactful, it's also something that the client can take a picture of. If you're doing it on Zoom, you can send it to them later. And it's kind of a reminder of the session and what you covered, especially if it was something that they were engaged in and interested in. You can also just use writing as a prop almost. Like I remember one time with a client, I did scripts because we know that people will really hold on to what they used to be or what they've always been in their lives. And he was holding on to a lot of things, but wanted to be different. So I took a piece of paper, wrote down the things that he says that he's always been, and I tore it up for him. And he said that that was so powerful. Like he really felt like he could let that script go and start his new one, or, you know, life without a script almost. So there's a lot of ways you can do writing, combine it with props. It's great.
Let me just comment for a couple of minutes and then maybe we'll go into questions and stuff. Just in talking to you, if you're going to go into this field of counseling, it can be a very, I hope this talk today is giving you permission to see that you can do a lot more than maybe you thought it was. Maybe you thought you just came in and listened to people's problems and either listened or you maybe thought you gave them a bunch of advice or whatever. But this profession, if you learn, one, you got to learn theories, and then you have to have an approach, and you have to have a way of having some sort of impact. That the name of my book is called Impact Therapy, the Courage to Counsel. And it takes a lot of courage and a lot of knowledge to ask hard questions. Cassidy has a client now, and she said, I never did ask her about sex in her former marriage. And she said, I think I didn't have necessarily the courage to do it. And I see I needed that. So this isn't a passive experience. And some of you might have your friends that come to you with their problems and you listen and you give them advice. But this is a whole bigger deal. The idea, you follow a map like RCFFC, you follow maps like theory, like REBT or transactional analysis, the idea that people are in their parent, adult, child, or there's a new theory out called IFS, internal family systems. It's the idea that a lot of people have a lot of parts. So I hope what this today has done for you is to realize that counseling can be a creative experience on your part. And it's not, and some people sadly teach it almost like it's you got to follow almost a program script and you can't say much. And I think what Cassidy said, once she found her personality and she was able to use that, it became more fun. And it really is a wonderful career. So with that, we'll stop for right now and take any questions or comments or hear from anybody.
First of all, thank you so much, all three of you, Dr. Jacobs, Çağla, and Cassidy, spending your Sunday morning with us. We greatly appreciate your being here. We definitely learn new things, and we got introduced new concepts. Probably we will read more and understand more. We will get your books and writings. I want to make a comment that in traditional Turkish psychotherapy, it's very hard to get people talk. It's very hard to get people disclose their life and issues, etc. It's really hard to warm up the therapy. I believe this type of like